As you'll see, I've admired the work that the NPDA has done. And what I'm going to talk a little bit about is, in this outline, I'll give you a little bit of an update from the Type 1 Diabetes Exchange, which is a registry in the US. It's not a population representative registry, but it is the largest sample that we have of type 1 diabetes. And a lot of the data that I'll show you is coming from a paper that has recently been accepted and should be out in the next month. So you'll have a little bit of an early view of that. I'll also give you just a little section on kind of an outsider's view of the NPDA, and I understand that the past couple of years you've had speakers from Sweden, and I think all of us aspire to have as good outcomes as Sweden, and you'll see that perhaps we're not doing quite as well in the US. I'll talk a little bit about some of the international comparisons that we've done, including your team, and also wrap up a little bit on diabetes technology. Can everyone in the back hear me? Am I loud enough? No? Let's see. And the second, is that better? No? The second question is my English accent, American accent intelligible? Okay, well, good. Is that better a little in the back? Louder? Louder? Better now? Okay, very good. All right. So this slide may be a bit redundant for this group, but why do we have benchmarking and quality improvement? Well, we certainly know that we have the data in type 1 diabetes to guide the goals of therapy. And it's not only that it's very clear the relationship of improving A1C to then improvement of future complications and improved mortality, but we also have data on quality of life, severe hypoglycemia, DKA. These are all important outcomes and something that we need to track and learn to do better with. And we need to know how we're doing now so that we can determine what we need to improve, and then also to know with ongoing data whether any of these new interventions we work on are actually having an improvement. And I think most importantly, and for all of us in the room, I think we appreciate it, and I think Fiona highlighted this, it's really a team effort. It's not just the doctors telling people what to do, but we have nutritionists, we have nurses, we have social workers, we have psychologists, we have pharmacists, we have a big team of people, and the families are incredibly important. This is just a slide I lifted from the American Academy of Paediatrics website, which is just one of the models for quality improvement, the plan, do, study, and act. And it's, I think, important to realize this is an iterative, continuous process. Sometimes in medicine we like to think we've made the diagnosis, given a medicine, and we're done, but really we're never done with quality improvement. So I wanted to just start with, this was the first collaborative work that we did with NPDA, and this is the slide that I presented, I think it was in 2014, Justin, in Toronto at the ISPAD meeting, and this was the first comparison also with the DPV group in Germany and Austria. And I had the pleasure of being able to present this, but then as I was presenting this, I realized that, and what we see here are data from 5 different countries, and the A1C in our pediatric groups, broken down then by whether the patients were on pumps or injections. And so as I was getting ready to present this, all of a sudden I felt a little bit of horror, because I was presenting data from someone else's registry and pointing out that they weren't doing so well. And I felt a little sheepish about that, and I'll always remember at the end of the talk that there was a group from the NPDA there talking, and I wasn't sure what they were talking about, but this went on then to be published, a paper in Diabetologia, so what did the NPDA do about this? And I'm sure this data is a little bit outdated for you, but I showed these data at a pediatric endocrine conference in the US last year when we were talking about quality improvement. And these were just some conclusions that I took from the NPDA website. And this was in the 2009 that the director said, "This disappointing situation cannot be allowed to continue. Action to prevent and manage acute and long-term complications of diabetes must start on day 1 of diagnosis and continue lifelong. NICE produced clear guidance 5 years ago, and more recently, why has so little progress been made in implementing it? Goes on to say, act now. The progression of diabetes is relentless. We have the knowledge. We need to use it and take responsibility and benchmark our efforts against others in order to improve further. Children and young people deserve nothing less. Well, I look up to the NPDA for the efforts that they have made. And I think these data, again, these are a few years back, but there have been improvements in the A1C. I think if you look at that bottom line, the 0.8% in A1C reduction in median A1C in a 6 to 7 year period, I think is very impressive. And I think everyone in the audience should feel quite good about that. Now, I think the topic of the day will then also be how do we continue to make more improvements. But I do think it's worth taking a moment to just reflect and feel good about the efforts that you've made. What you'll see then is I'll present data that we're not doing quite so well in the US. And I think in the US we need to learn from the work you've done, from others in Europe and how they've made improvement. These are data from the T1D Exchange. There are about 25,000 patients. These are already data that are from earlier in the 2010 to 12 period. But what you'll see is this has data in people all the way from 2 years up to 80, and then graphs out what those averages are across the lifespan. And you'll see that in particular in the pediatric age range, we're really not doing so well. And I think, how many people have seen this slide before? Yeah, I'm getting tired of showing it, and especially that we're not doing so well. So one of the takeaways here will be a tale of two registries, and so let me jump into some of our, I've had to tried to get some English culture in here, I guess, so that was the best I could do, thank you. All right, so these are data then that will come out in the paper in DTT in the next month or two. So you'll get a bit of a preview of that. And again, these data are from 2016 to 2018, representing 22,000 people with type 1 diabetes. So one of the takeaways is that the people in the registry are frequently overweight or obese. And just to orient you to these slides, we've got the different age ranges, less than 6 to 13, etc. And then in the orange, we've got the data from 2010 to 12. And then in the blue, the data from 2016 to 18. And so you'll see that in many of these age categories, there's been an increase in the amount of obesity and overweight. Historically, 30 years ago, obesity and overweight weren't really a problem in type 1, but increasingly it is a problem in the US. At least people with type 1 are just as overweight as people who don't have type 1. And the worry is that this adds then another cardiovascular risk factor and with negative consequences for long-term health. Just to point out, we are part of a consortium at Stanford that is looking into this as part of an NIH grant with colleagues at University of North Carolina and Florida to try to understand more and generate data on what can be some evidence-based recommendations looking at not only A1C as an outcome, but healthy weight as well. So moving on then to other data from the T1D Exchange, these data show what the change has been in insulin pump use, again from baseline to the 2016-18, and you'll see overall in the cohort it's gone from 57 to 63%, with some increases in most of the age groups, and particularly in some of the young children. However, despite this, we do continue to have racial disparities in the registry in insulin pump use and also in A1C. And this is even after adjusting for socioeconomic status. And so you'll see in this, we broke down pump use by income level, but then also by race-ethnic status, and you can see that there's disparities between the self-identified white versus African-American and Hispanic, and that these persist even at the higher socioeconomic level. So we need to take this to heart and try to figure out what is going on that we aren't providing care in an equitable manner, and I'll come back to that in the diabetes technology section at the end. This is important because we see lower A1Cs in all different groups, whether you're on a pump versus injection. And some of those disparities are the largest in the African American group, where there's much higher A1Cs. So again, I think we need to be using this registry data, the audit data, to understand where we're not doing well, where we need to improve, and then to design action to intervene and do better. So one of the more recent, I think, messages when looking at the data is that historically DKA had been elevated in patients who used insulin pumps compared to injection users, but in the most recent data, in fact, that was not the case. And again, these are observational data. This is not a randomized controlled trial, but when you look either overall or in the different age groups, that the patients who were on pumps had lower rates of DKA than those who weren't in the pumps, and it was about almost half as many DKA, and that's something that's a little bit different than in the past data. So how about continuous glucose monitor use? And I think this is something where we've seen a big increase when we look at the different age groups again, and then when we look at the baseline, which was 2010, especially in the youngest children, we see an increase from 4% almost up to 50% in the 2016 to 18 data, and that continues throughout the age span, but particularly in the youngest children. Another way of looking at the CGM data are to look at by year, and you can see that there's been a real increase, especially in the last couple of years. I think my observation is that in 2018 and coming up in 2019 in the US, we're going to see an even greater increase. I think this is because some of the technology itself has gotten much better. Currently with the Dexcom G6, you do not have to calibrate it. It has been approved by the FDA for insulin dosing decisions. It also has a filter, so acetaminophen, Tylenol doesn't affect the readings. And so when you explain to a child that they can either use this continuous glucose monitor or they can poke their finger 6 to 10 times a day, it's pretty clear to them which one they want. If you explain to a parent that they can have information on their child's glucose every 5 minutes, and furthermore can go up to the cloud and down to their cell phone if they wish, they like to have that as well. So I think this is a big advance in our ability to take care of children, adults as well, with type 1 diabetes and type 2 diabetes. So I think this is going to be a big change for us in the future. And to remember that CGM use, in this slide we look at it again by age group, but the rates of CGM use, whether you're on a pump or an injection. And I think 3-4 years ago, most of our patients who were on CGM were on pumps, but in the last couple of years, I think that's expanded to people no matter how they deliver their insulin. And again, why is this important? Well, in this slide, which is a little bit busy, we've got age groups under 13, 13 to 26, and over 26, and then we've broken down what their observed A1Cs are based on whether they had injection only, pump only, injection plus CGM, or pump plus CGM. And you see in all categories that the addition of CGM, they have lower A1Cs, which makes sense. If you have more data and you use it, you should be able to get better control, in theory. All right, well, let's shift gears just a little bit and talk about the relationship of A1C to severe hypoglycemia. And I think we're all familiar with this slide, or a version of this from the Diabetes Control and Complications trial, where you saw that as the A1C is higher, the risk of vascular complications increases, and increases in a curvilinear fashion. But then the second part of that graph was that as the A1C was lower, your risk of severe hypoglycemia also increased dramatically as well. And so I like to put a big X over that, because I don't think that the data bear that up anymore, and I think there's been progress, and I'll show you several slides to try to support that. Now, having said that, severe hypoglycemia is still a major concern for us, but I think it is possible to get lower A1Cs without that dramatically increased risk of severe hypoglycemia. And so here are the data from the T1D Exchange on rates of severe hypoglycemia by A1C category, and you can see that actually the lowest rate of severe hypoglycemia is in that 7 to 8% range. And while there is an increased inflection here, it's not until we get down less than 6% or even less than 6.5%. And actually there's some higher rates of severe hypoglycemia in those patients who have the highest A1Cs. So having a higher A1C doesn't necessarily protect you against having severe hypoglycemia. All right, so I told you that we aren't doing quite as well as we would like to be in the US, and most of our patients unfortunately don't achieve the American Diabetes Association A1C goals, which are 7.5 in the pediatric population and then 7% in adults. And you can see that both at baseline in the 2010-12 and then the current data, that roughly a quarter or less of our patients in any of these age groups are meeting the A1C goals for the ADA. So this next slide then is the one that I think I find most discouraging. I wish that these curves were reversed. The orange line is the baseline. That was a version of that I showed in that first slide. And then unfortunately, the next slide, the next graph is where we are now. And so I've decided to put Buzz Lightyear in there because I sure hope we don't go to infinity and beyond. But I put this in because I don't feel very good about where we're going with this, and we need to have some action. And we haven't had any action. So I don't mean to be making light of this. I think this is very serious, and I think we need to take action. And I think the NPDA has shown us that you can bring A1Cs down. And in the US, we need to get our act together. So I'm going to show Buzz Lightyear with this slide, and hopefully we can shame ourselves into some action. So what about some T1D international comparisons, and some of these will include the NPDA work with your team. Here again is a slide. We showed this at the ADA a couple of years ago, and this was comparing, again, it's that same curve from the T1D Exchange, but comparing this then to the DPV, and you'll see that the biggest gap then is in the pediatric population. When we look at the adult data, there wasn't a whole lot of difference. Now there could be some epidemiologic explanations for this. The US database is not necessarily population representative, and the adults who make it into an endocrinology clinic tend to be better controlled than those who don't, but still we see a dramatic gap of about 1% across the pediatric age range. And I think this tells us we need to take stock of what we're doing and make some improvements. The first paper that we put out as far as international comparison was with the DPV group, and we compared the youngest children in both registries that were less than 6 years of age. And between the two registries, we had 2,600 children. And we again observed that the German Austrians were doing better. They had a much better A1C, 0.8% better. And then when we looked at other data, in this slide we compare the T1D Exchange to the DPV by A1C categories, less than 7%, 7.5 to 8, or greater than 8%. And we see in the first panel that for severe hypoglycemia, there was no relationship to your A1C and how much severe hypoglycemia you had. But then in the second slide, there was indeed a relationship between having higher A1Cs and having more DKA, which was not surprising. But again, at the time, the ADA had set higher targets for the youngest children with the idea that that would help prevent severe hypoglycemia, but the data did not support that. Shortly after this paper, I think this helped contribute to the ADA making the decision to lower the goal to 7.5 across the age group. So more on severe hypoglycemia, and these are data. I want to thank Dr. Elizabeth Davis from Perth who shared this slide for me. And again, I start with that curve from the Diabetes Control and Complications trial showing that The lower your A1C, the higher your risk of severe hypoglycemia. Now remember, these were data from the late 80s and early 90s. Insulin pump use was decreased. Glucose monitoring wasn't quite as good as it is now. The types of insulin were different. They had Lente, NPH, regular insulin. So there's been a lot of changes. I think hopefully that as healthcare teams, we're doing a better job as well. And so they've shown that over time, there's been a flattening of that curve on the relationship of A1C to severe hypoglycemia. So we took data from 3 different registries, the Australian, the T1D Exchange, and the DPV, and saw that this was fairly consistent across all 3 registries. Again, suggesting that it is possible to get lower A1Cs without having that increased risk of severe hypoglycemia, and this was in pediatric diabetes a couple of years ago. All right, so let's move on to DKA, and this again was a paper with NPDA as well as the German group, almost 50,000 pediatric patients, and one of the take-homes of this is that in the patients with type 1 diabetes who had been diagnosed at least for a year, so these were not newly diagnosed patients, but existing patients, that in the past 12 months, there was 1 in 20 in the DPV, 1 in 16 in the NPDA, and 1 in 14 in the US registry that had a diagnosis of DKA and required treatment in a healthcare facility. So I think this is way too high. DKA is largely, if not totally, preventable, and I think this is there's all kinds of reasons why we should be moved to action from this paper, and I hope that that this has highlighted another area where we can all be improving. This next slide, I'm not going to spend much time on these next 2 because Dr. Stevenson will give us more detail on this, but this was a paper out recently with 8 different countries, and this was with the initial NPDA and T1D Exchange data, and you can see that US, England, and Wales were off on the side there where we don't want to be, with higher A1Cs. Again, this is the base, I think, the earlier NPDA data, and there have been improvements. One of the take-home points on this that you'll hear more about later is looking not only at what the average A1C were for each of the 8 countries, but then also what was the distribution and the variability. And so that could have implications from a national system that not only do you want to lower your average, but if you have outliers, you might want to figure out either how they're doing better, or if they're outliers with higher A1Cs, what sort of help might they need to get down and lower the mean for the group. All right, you'll hear more about that, so stay tuned for the next talk. All right, so another international registry is called the SWEET Registry. Has anyone heard of this registry before? Okay, so yeah, and Ragnar probably spoke about it a couple of years ago. So this is, the vision is equal high quality care for all children with diabetes and try to harmonize, optimize outcomes for children and adolescents with diabetes worldwide. This is, there we are. And then here is a picture. This is already perhaps a little bit outdated, but there are close to 50,000 patients that are in this registry, and mainly in Europe, but it is also expanding across the globe as well. And I think one of the take-homes from this is that when you compare the 2012 to the 2015, and I think there's another analysis that's in progress, that there have been improvements, that there's been a shifting to the left, even though there have been more countries that have been added, more clinics added in the past few years. So again, some of the same principles with NPDA of monitoring your data, trying to identify what's working, what's not working, and then developing plans of action to improve. So this is the most recent data from 2018, and what this is, each line represents a different clinic in the SWEET data set, and you can see that the median across there is 7.9. And you've got the groups with green that are less than 7%, then you've got the groups in yellow, And by full disclosure, this is where our clinic sits. And so I think one of the steps, and you've done it here, is to be unblinded with your data. And that probably was a little bit scary for some at the beginning. But I think the only way we can learn from each other is to try to be transparent and say where we are. So I've told our institution that I'm going to show this slide. And I can tell you that Stanford does not think they're a bottom quartile institution across the world, but that's where our data is. And I think, however, as I tell our team, we should not be too discouraged because while we cannot say for sure how we would rank within US data, I think if you looked at those previous slides, 8.3 probably is doing pretty well on a US standard, but we need to acknowledge where we're at, and we need to learn from the people on this side and try to start moving our data in that direction. So that's where we are. One of the things that we've learned in the last year, and these are data that we presented at ISPAD a few months ago, is we looked at our new onset patients in the last 4 years and just tracked what were their A1Cs. And this is how it looks. Obviously, you get diagnosed and you didn't know you had type 1 diabetes and your A1C is high. You start getting treated, you go into the remission or honeymoon phase. We see that it bottoms out at about 5 to 6 months, and then we get this slow creep back up. And so there's very clear physiologic explanations for that, right? The beta cell function is continuing to deteriorate, the honeymoon phase is waning. But I can't help but think we've got an opportunity there, and that's where we should be focusing more of our resources, that perhaps every 3-month visits aren't quite frequent enough, because we'll see these patients come in, and all of a sudden they go from maybe an A1C of 6.5 to 7.5 to 8.5, and it's very hard to get those glucoses, average glucoses back down. So we're instituting a program to try to focus the resources that we have in the new onsets and early on. We're also trying to use CGM early on at diagnosis as soon as we can to get that to patients, and then also to have a program where we're able to get that CGM data in more frequent intervals than every 3 months so that we can make an adjustment, because you really don't need to have a face-to-face visit. You could perhaps do it over the phone or with telemedicine to be able to look at the data together and increase an insulin dose. So these are some of the things we've learned and are trying to implement. All right, so I think I've got about 12 minutes left here. I think we're doing okay. Just gonna shift here a little bit to diabetes technology. One of my mentors was Dr. Peter Chase, who writes the Pink Panther books. He's still going strong as a professor emeritus. And this is a slide that I took from him, and he has been practicing diabetes for I think close to 60 years. And he would talk about the 3 eras of glucose monitoring. Does anyone remember that first era? It was basically a chemistry experiment that you were asking patients to do, and then at the end you'd say, well, it looks like it was maybe a little high, right? It was very hard to use that data to help you. And then we had meters, and that was a tremendous advancement. And then we've got continuous glucose monitors, we've got pumps. I think artificial pancreas is on the way. And I think it's been in the last 3 to 4 years where we've had continuous glucose monitors that have been beyond experimental, and Dr. Chase put in 2003 because he initially did work with the GlucoWatch and other systems way back when in 2003, but I think it's probably more fair to say this is really the last 3 or 4 years clinically. So what has it looked like as far as uptake of CGM? And these are comparisons with the T1D Exchange on the left, the DPV German group on the right. We broke these down by the less than 6-year-olds, the 6 to 13, and over 13 to 18-year-olds. And you can see that there's an inflection point in the US in about 2013 and a steady increase. Then in Germany and Austria, we've got an inflection point at 2015 going to 2017. Most likely A function of the CGMs that were available in each country, I think, is probably the Abbott Libre in Germany and Austria, and whereas in the US, I think it's more with the Medtronic and Dexcom systems, although we are seeing more use of the Libre. So one of the other themes then is disparities, and as I worry that as we have more diabetes technology, that some of the disparities that we've seen may broaden, and we're seeing, again, on the T1D Exchange, more of a disparity between minority and non-minority use of CGM, less so in the DPV group. And I'll note that the variable they use is migration history, indicating whether one of two parents are from somewhere other than Germany and Austria. So it's not exactly apples to apples, but it was the best we could do. So again, why do I think CGM use might be important? Well, it's again more data, it's more usable data for the patient. You have alarms to let you know if you're high or you're low. And then again, in this observational data, we see that the A1Cs are lower in the patients who are using CGM, and that holds whether you're in the US or Germany or Austria. So one of the things we've tried to do is improve access, and this is one of our junior faculty, Priya Prahalad. This was her project. It recently got published. Sustained CGM use and low-income use with type 1, and it has been a struggle to get CGM approved for some patients if their insurance coverage is not good in the US. And what we intended to do with this is to show that if you do in fact fund these CGM use in these patients, that they will in fact use it. What we showed is that at 6 months, almost 80% of them continued to use it. Their A1C stayed stable. This was a database review. This was not a randomized controlled trial, but their A1C stayed stable. They had very low levels of severe hypoglycemia, 4%, or hypoglycemia, excuse me, 4% less than 70. And I think some of the points we're trying to make at this, there's no reason to believe that people with lower socioeconomic status behave any differently than people with more substantial means and use of CGMs. And then also the point that as diabetes technology becomes more effective, it's important that all people with type 1 diabetes are able to benefit. So one of our frustrations is that the insurance companies will quote old data that says that children and adolescents won't wear CGMs, and that's of course with 10-year-old data and outdated systems. So we hope that this has a positive effect on getting approval for our patients. So I'm not going to talk much about artificial pancreas today, just wanted to highlight one point here. This was a paper from the 670G, the Medtronic system, and I believe, Fiona, you said you have some patients that are using this. Oh, there we go. And so we could talk more about this, but this was an extension of patients from Stanford, Yale, and the Barbara Davis Center in Colorado on use of the 670G system. And one of the take-home points on this is that auto mode, or the closed loop part of it, as opposed to the open loop part of it, in the first week in these adolescents was 87%, and then that went down over 3 months, down to 72%. And that's important because the more time you're in auto mode, the more time that the closed loop system is working and helping you. So not to pick on this system too much because it is the first system, it's first generation. They were constrained by the FDA on what the algorithm could do. It's helped a lot of people. I see shaking heads that at least one person in the audience has had great benefit from it. I think it has been a wonderful advance, but also there are some challenges with staying in the closed loop that I'm sure will be improved upon with future generations. So I think it's very important with all of these diabetes technologies that we have realistic expectations, both as the providers and as the families and the people who are using them, exactly what you're getting. These are not magic. They do take some training, they do take some work, and they can greatly improve your outcomes. but they need to be more user-friendly, and I think that is being shown by the uptake of these systems that they are in fact improving. All right, I've talked mainly about A1Cs and DKA and severe hypoglycemia, but I think another important concept is patient-reported outcomes, and there was a national workshop that the NIH and ADA organized about a year ago, and this also included patient groups. It's very important that we have these patient-reported outcomes. Indeed, the patients are the users for all these treatments. There were many psychologists there, and there's some important methodologic concerns that need to be worked through. But there was clear consensus that these PROs should be used to illustrate outcome impacts, assess treatment benefits and their tolerability, and help guide clinical decision making. So I think we're going to continue to hear more about these, and it's very important that we listen to what patients have to say and how are these systems working for them, how are the treatments and therapies working, and quality of life is a very important concern. So two sets of diabetes technologies have come out in the last 6 months. One is from ISPAD, and I just put these up there. These are both, for reference, these are both first versions, both for ISPAD and then also for the ADA. The standards of care just came out in 2019. And I think this is very important that we have these organizations providing data, evidence-based guidelines on how these systems work. It can be important in the US to get support for these from insurance companies and others. However, one of the concerns I had as I was part of these groups is I worked with colleagues who kept talking about older data. And so how many of you are familiar with the 2008 or 2009 data from the JDRF CGM study? So this was really the first, it was a landmark study. It showed that in adults, use of CGM, you had better outcomes. And so that was very important to move CGM forward. However, when you looked then at the adolescents and the children, that they didn't wear them. And so if you don't wear them, they don't work. And what's been frustrating is that these data from systems that are 10 years old, if it continued to be referenced as an excuse for not supporting CGM in youth, and this is like saying, this is a Michael Douglas in Wall Street. Remember that? He had a phone and he could walk outside of his house and talk on it. And I was very impressed when I saw that. I think I was in college. And who would have thought that, we'd all have cell phones and surfing the internet now. So it's a bit like saying, Michael Douglas couldn't surf the internet on his phone, so don't buy an iPhone now. So remember that some of this study was an excellent study. It's A-level evidence, but it's A-level evidence with outdated technology. So to apply that 2008 data to current technology, I don't think is quite fair. This is just one of many reports that just shows how the quality of the data with CGM has improved over the past decade. And this just goes up to 2015, but there's many more that have improved since then. We recently had a paper again with Dr. Prahalad that was in diabetic medicine. Who knows what the future brings, but we were asked to speculate on this, and I think there will be more technology, there will be more patient-reported outcomes. We had a little bit of a discussion about telehealth and education, and we have a couple of programs with that. I think the electronic medical records, the quality improvement, the benchmarking will continue to be very important. Big data is incredibly important. And then I think the partnerships, I think with this technology between academia and industry will be important, but I also think between the providers and their patients and family is extremely important if we're to make progress. So with my last couple of slides here, I think in summary, I do think we're making progress worldwide on reducing A1C. I think there are numerous examples of successful quality improvement processes in pediatric type 1 diabetes, and I think you all should feel good about the work that you've done. I think that the NPDA is a very positive example of how a group can come together, work hard, and make improvements over time. Now, the rest of the day, you're going to hear talks about how you need to do better, right? And I think it's an ongoing process, but to at least take a moment and reflect on that, and in comparison to how some other groups are doing. I think that diabetes technology has great promise, but I think we also have to be aware that access to these technologies is very important, and we need to be cognizant that disparities could widen unless we provide access to these. And then I think for my own colleagues at home, that the US, I think, clearly does not seem to be keeping up with A1C outcomes compared to international results, and we have some work to do. All right. Has anyone gone to an ISPAD conference before? Okay, so next year it's in Boston, and also all of the talks at ISPAD are freely available on the website. I mentioned that Justin gave a very nice talk in 2017 that highlighted NPDA data, and so those are all available. And again, thank you very much for the opportunity to come and speak. And I look forward to meeting people and talking to you. And if there's time, I'm happy to take any questions.